And I have a tough achievement now to keep you awake. That is not easy. But I have also a tough argument to talk to you about. And just to start, I will try to challenge you now with one statement that comes from the 18th century that tells what are we doing every day. And this is what and how I feel when I'm in front of a systemic sclerosis patient. I'm there trying to keep the patient happy, doing anything I can, like a joker, because in reality, I know, or probably I knew, that I can't do anything for a scleroderma patient. So just looking at this is Voltaire in the 18th century telling something that was very true from scleroderma. But I have to tell you, this is not the way I feel today, because I strongly feel that we have to change something in scleroderma. And that's the reason why I will try to present to you what is the lung involvement, the definition, the way we investigate, the way we treat, even if we are far behind to any other kind of rheumatic disease today. You see that interstitial lung disease is one of the 4 causes, is connective tissue disease. There are many others. But one is connective tissue disease with systemic sclerosis, with mixed connective tissue disease, with dermatomyositis, antisynthetase antibodies syndrome, and so on. But when you look at this, you see that in comparison to other connective tissue diseases, systemic sclerosis has a large, fair amount of interstitial lung disease, but in particular has the vascular component. So today, I cannot speak to you about the vascular component. I will stick only to the interstitial lung disease, even if they are connected, and it should not be correct to divide them one from each other. So this is the prognosis of systemic sclerosis patient. And you see that as much as we are piling up with internal organ involvement with the lung, without vascular, but with the vascular, you see that the perception of life is changing and survival is changing dramatically. So interstitial lung disease involves the parenchyma, the alveoli, the alveolar epithelium, the capillaries, and obviously everything that is in the middle. And you see here that inflammatory infiltrate is the main element, the main point that is driving us when we think about the treatment. You remember the question of the lady this morning? So how is inflammation autoimmunity? In reality, here is the same fact. And we know also that interstitial lung disease is now, today, the main cause here, the main cause in 2000 of the death of our patients. From more far away from the kidney system that in the beginning, in the 70s, here scleroderma renal crisis was the #1 cause of death. Now, let me just show you that more severe lung disease is obviously linked to a worse survival, and that's clear. Now, this is the interstitium, and you see here that we can spend from 40 to 90% of the patient having lung involvement. I would say 85% of the patient. And we have 2 kinds of lung involvement from the pathological point of view. Non-specific interstitial pneumonia, and you see here inflammation. You see inflammatory cells invading the interstitium here. You see here, from here to here, the thickening of the alveolar membrane, and this is a predominant event in scleroderma patients. Up to almost 80% of them have this kind of pathological feature. There is another one. is usual interstitial pneumonia. And you see here is different because there is a concentrate of inflammatory cells in one part, and this infiltrate is then followed by a huge accumulation of myofibroblasts, the bad guys, really the bad guys in the whole picture, who are producing a quantity of collagen, and this is from 8, maximum 26% of the cases. And you see here which is the difference in perspective. UIP, usual interstitial pneumonia, this is the survival. This is non-specific, still inflammatory and cellular. This is fibrotic. You see, so the two pathological issues have a role in the possible prognosis of the patient. And you see here the proportions. This is scleroderma, where NSIP is predominant. Lower is the UIP. You see this is UCTD. Maybe UCTD is a scleroderma case, but we cannot discuss this now. But you see myositis, you see here Sjögren. So you know that in all connective tissue diseases, and even in rheumatoid, you can find these two pathological features of the diseases. So now, the main manifestations of interstitial lung disease from the clinical point of view are very scarce. You have cough, non-productive. If you put the stethoscope on the chest, you will hear crackles bibasilar in these areas here. You may end up with right heart insufficiency, but far away in the history of the disease. And you may develop progressive dyspnea. And progressive dyspnea can be due to the interstitial lung disease as well as to the vascular involvement. And so the diffusing capacity for carbon monoxide, DLCO, is for sure one of the most sensitive and earlier technique with which you can detect that something is going wrong in the alveolar space. And you see here that we have pulmonary function test, we have CT scanning. Don't consider this chest X-ray as an element that is fundamental, because when you see the modification in the chest X-ray here, it's too late. So our reference today are the pulmonary function test as well as the CT scanning. And you see here that we have DLCO, that is the most early modification in the transfer of carbon monoxide, but we have also the forced ventilatory capacity, FVC, that when you see the FVC changing, probably it's too late. It will change. It will change. And many trials are considering FVC as a reference element, but in reality, when FVC will change, it will be too late for your patient. And you see here, this is DLCO as well as FVC. Both of them predict survival. Poor survival for those who have a DLCO below 30 in comparison to those who have FVC below 70 here that are a little bit worse than those who are over 70. And CT scanning. CT scanning is today a recognized worldwide technique to be used to detect the modification in the lung. Don't forget that usually a CT scanning is 400 chest X-rays. So you cannot use CT scanning continuously. I'm just telling you this, and you will understand why I'm telling you this, because you cannot every 4 months make a CT scanning. It's absolutely dangerous for the patient. But however, CT scanning is giving us a lot of information. What is the condition of the parenchyma in the moment you are seeing the patient? And you can see, starting from ground glass opacities up to honeycombing, but we have to remember that the CT scanning is a very important element, even that is more sensitive than chest X-ray. This is one of our papers more than 10 years ago. So in the appropriate clinical setting, CT scanning can give you enough data that you see here, depending on the phase of the disease, that may allow you not to have a biopsy or to have a bronchoalveolar lavage, and we'll discuss this now. So you see here, this is the very early beginning, just a tiny cloud here. This is the ground glass. Here, a little bit more evolution, honeycombing. No way back. Maybe something we can get here back, maybe here we can get back. So it's a matter of time. It's simple, it's a matter of time. So as soon as you hit and you strike the disease, you will be able to avoid this dreadful evolution. And you see here, ground glass, classic ground glass here. The question is, ground glass should not be called alveolitis, please. Ground glass is ground glass, because you don't know how much this ground glass is only inflammation or is already fibrosis. Because this might be already fibrosis in many areas. And you see here this modification that can tell you something is going more wrong than just a simple inflammation. And you see here, today, we can even try with the CT scanning to identify the classic NSIP, non-specific interstitial pneumonia, as a pattern. This is a pattern that is NSIP and closely resembles those who are in the idiopathic form of pulmonary fibrosis. I told you before about bronchoalveolar lavage and biopsy. So the biopsy today can be performed only if you have really problems and you suspect something else. Because you cannot do this routine, or you cannot repeat this routinely just to see what's going on into the lung. The bronchoalveolar lavage 10 years ago was one of the must. I lavage patients continuously, despite their not being very happy about this. But today, we know that we can use bronchoalveolar lavage when you suspect malignancy or when you suspect something else like hypersensitivity, or you have a suspect very seldom of pulmonary hemorrhage that may happen in scleroderma, but it's very seldom. This is not lupus. So we know that neutrophilia was one of the main elements in the lavage, but this is the point. The assumption that neutrophilia identifies an inflammation in the lung is something that is today not true. So that's the reason why lavage today has not really an important role as a prediction factor to what will happen or what is going on in the lung at the moment. So the recommendation is you can use lavage only in a minority of patients, not in every patient. Only if you have a specific question that you want to address, and the BAL can give you an answer to what you want to know. Now, let me go back a little bit on something that I've told you this morning during the discussion. Ultrasound. Is really ultrasound something that is helping us in understanding these patients? Something very simple, no radiation, you can repeat this anytime you want? The answer is yes. Still, we are far behind of what we would like to have, but the answer is yes. And I will give you now the proof of this. So you see, this is a CT scanning. If I have my probe in my hand, what can I see of this CT? And this is the evidence, the ultrasound equivalent of a CT scanning. And you see here, this is a CT scan normal. This is normal sonography. This is a diffuse, interstitial diffuse disease. And you see here, these were called comets. And today are called actually B lines because they derive from the studies done in the pulmonary failure. You see here, this is just an ultrasound going on, and you see how you may see these comets or B lines that are just showing you that something is going wrong in this lung, and this is a specific cohort of patients. These are patients that we have analyzed. This is published last year in Annals, because these are very early patients, very early, where the manifestation at the CT scanning are very few manifestations. So what came out, that we were able to find B lines in those who are positive on CT scanning and no B lines on those who were negative on CT scanning. And moreover, just taking the ultrasound and saying, but which will be the prognosis of this patient? How they will improve or worse? And this is the answer. In those who have more than 20 B lines, the survival rate is dropping down in comparison to those who have less than 20 that are still stable. So in conclusion, we know that B lines can be correlated with CT scanning, and moreover, and this is the new information we have provided to the literature, is the fact that the CT scanning gives you the beautiful images of what is going on in the lung. And probably we will not be able in the future unless they have the software enormously increased technically, but we don't know yet. But what we know that the screening now, the screening of this patient can be done by the ultrasound. I don't have to use CT scanning. If I have 0.0 with CT scanning and ultrasound, at this point I will follow up the patient. If the B lines are increasing, that's the moment to scan the patient, but not just random. So at the moment, we know that the screening can be done very usefully with the echo. Now, the question is also, how much severe is this patient? And this is very simple. This comes from the Brompton Hospital in London, the biggest center in the world for this, for interstitial lung disease. And you see that they were able to identify the extension. Below 20, we call this a limited lung involvement. Over 20, extensive disease, and usually we couple these data with the FVC, because FVC is very reliable for what means the extension, and in particular the fibrotic evolution. In fact, the extensive disease is very important, but, and this is published a few days ago by an Australian group, you have to not to forget that CT scanning is good, but always you have to couple the pictures with the function. So what's going on with the LCO, what is going with FVC, what is going with CT scanning, in order to understand how much the patient may deteriorate in the next future. And the question is, which patient will progress? I'm taking this, I don't like this work, but I took this work only because of a reason. Because it's telling you that the inflammatory markers are elevated in those who progress. Yes, this is true. Sedimentation rate can be increased, but don't forget that this is a minority of patients. It's true, we can understand this, but in the majority of patients, the disease is silent. ESR, sedimentation rate, C-reactive protein don't move. Despite this, after 6 months, you will find the lung ravaged completely. So this is a warning, okay? Because what is written in the literature is beautiful. It's beautiful. But the truth in practice is a little bit different. This is just becoming clear because statistical approach can give you anything. But the reality is that you miss the patient. If you think that the inflammatory markers will definitely give you the whole picture in all patients. Now let me go to the treatment. And the EULAR treatment, the EULAR group with the EUSTAR have developed what we call recommendation. And I will start from here because in the recommendation, the only evidence-based data we have are about cyclophosphamide. And there are two studies. One in the States, this one, Scleroderma lung study, and this is the FAST study in Great Britain. Please consider that this study is oral and approximately 100 milligrams per patient. This is intravenous with cyclophosphamide, only with 600 milligrams per square meter. This is 2006. 600 milligrams per square meter approximately could maybe something like in a normal man around maybe less than a gram. This is what they proposed. Today, we are at 1.5 gram per square meter, just for you to understand. So the capacity to aggress is growing, and we are even more going up with the dosages of cyclophosphamide. So two beautiful studies. You see here, this is a little bit tricky, not really what they wanted. Here, it's barely significant after 6 months. So here are the data. It's very simple. Look this. 12 months, they are diverging. Controls from cyclophosphamide. This is cyclo, this is control. It seems everything to go well, and then abruptly, at 24 months, everything is dropping down. So whatever you have gained, this small difference that seems to open up, in reality then goes back to what we had before. So the efficacy of cyclophosphamide seems to be moderate for the moment. It mainly frees the lung in that situation, and obviously is associated with adverse events. We know this. However, let me show you this. I showed you the classical way of administering cyclophosphamide. Classical way. 600 up to 1.5 grams of cyclophosphamide per square meter in pulse treatment for every month. But this is a transplantation. This is an autologous stem cell transplantation. And these are the results. This is published in 2011. And you see the differences before and after. So there is a good difference. But here, the administration of cyclophosphamide is totally different. Here, we arrive to from 14 to 20 grams in one shot. And you will see at the end of my talk what I mean with this and the differences. So it's a completely different approach. And you see clearly that you are able to clean this lung, but what is fibrotic remains fibrotic. So what means we can clean inflammation, but it's very difficult to clean fibrosis. Mycophenolate that we use in lupus now seems an alternative. This is a good example. Now there are many other papers coming out. This is still London, the Royal Free, but there are many coming out just telling you that possibly mycophenolate mofetil could be used in the lung involvement. Then we have azathioprine, we have CD20 antibodies, and you have heard about the stem cell transplantation. So this is azathioprine. Azathioprine usually is not the first line. Azathioprine can be used as a maintenance therapy. You use for 6-12 months cyclophosphamide, then you maintain with the azathioprine or an alternative with mycophenolate to control the lung. This is mycophenolate. This is a very nice, few days ago came out. This is called CT scanning histography for pulmonary fibrosis. And you see here, this is a pulmonary fibrosis that is picked up with this technique, and this is the effect of mycophenolate before and after. I'm not very familiar with this. Maybe, I don't know if our colleague can tell us, but this is brand new that came out now in the literature. This is another treatment. This is another interesting treatment. You see here, they were able to clean whatever they could of inflammation and just remaining, you see here the cleaning, just remaining the fibrosis. You see this is a subpleural lines here. And this is rituximab, anti-CD20, anti-B lymphocyte therapy. So in this case, they were pretty successful even if they were not able to clean fibrosis. So we know now that even rituximab can be helpful. These are the data. This FVC, this is the LCO. You see from baseline to 48 weeks how much is the improvement in these patients. So we have also the hope that rituximab could help us. Now, when you see this chart is 2012. We have a lot of actors. We have a lot of actors in lung inflammation. We have one bad guy, the fibroblast. Why? He's not poor guy. He's not really bad. But he becomes very bad. Why? Because he transformed himself in a myofibroblast in the lung and in the vessels. And so this is a terrible event. When this myofibroblast, with all this stuff, is activated, is triggered, he becomes a monster. He enters the vascular wall. He colonizes the vascular wall until the vascular wall is completely occluded, pulmonary hypertension. And then he colonizes completely the alveolar space, the alveolar membrane, and transform the alveolar membrane in a desert full of collagen. So how can we target all these factors? And we have, obviously, the problem is who should we treat? Also with the forthcoming treatment. Patient with severe disease, patient with progressive interstitial lung disease, but what is the problem? We should treat patient with early disease. We should not wait. Why shall we wait for fibrosis? We have to treat them before the scar, before fibrosis, because when the scar is there, we will not be able to cure the scar. So the problem is when. If you look at this slide, this is a very simple work that has been neglected. This is coming still from the Royal Free in 2002. What is telling you this slide? DLCO and FVC, 1 year, and 3 years later. Which is the difference? None. What does it mean? Here, 25, 29, 43, 44, after 3 years. What does it mean? The damage has been done here, very early in the disease. Then, few things are changing. So what means this? That you have to strike the patient as soon as possible in the early phase of the disease. Now let me go back to the dosage of cyclophosphamide. And I try to chart this in the way that you can understand. This is a paper that will be published this year in rheumatology. So you have, these are the classic, this is the oral, 100 milligram per day approximately, continuous. This is intravenous monthly, 600 milligrams per square meter. This may be 600 per square meter up to 2,000 milligrams, up to 18 months. Which is your limit? Your limit is 30 grams because you cannot treat the patient with more than cumulative dose of 30 grams of cyclophosphamide. So you see here, you're just pulsing. At the end of the day, you will arrive probably here, very close, but the regimen is totally different than this regimen. Because this regimen, mobilization and conditioning, with a total dose of 1420, will arrive with the same dosage, cumulative dose as this, but in a completely different way. So this is what we call hematopoietic stem cell transplantation with a conditioning, very heavy conditioning that is approximately 14 grams in one shot of cyclophosphamide with the rescue of stem cell treatment for this kind of patient. So you see here, the problem is which regimen you will choose. Which patient you will put here, which patient you will put here or here or here, and which is the dosage you will choose here. Because this will make the big difference in the way you will you will manage and you will strike the disease as soon as possible. So the immunosuppression is needed because we have the infiltrate in the tissue. It's important to be very early. Cyclophosphamide can help you for sure. You have to choose which kind of dosage, for how long, and how you will strike the disease. In my experience, high dosages of cyclophosphamide are the best approach in the very early phase of the disease. So the take-home messages are very simple here, and interstitial lung disease is leading to death, very bad death. Usually the restriction affects the patient at least 50%. Pulmonary function tests are very important. Function plus picture imaging with CT scanning. The treatment is recommended for those who will have a progressive disease, and the decision should be made, obviously, in the assessment on individual benefit-risk ratio. And I would like to thank all my coworkers that work with me in the Reference Center for Scleroderma in Florence, because without them, I could not be here talking to you, obviously. And I want just to remind you that the next World Congress on Systemic Sclerosis will be held a year time from now in Rome, February 6-8, 2014. And I thank you for your attention.